the breadth of what breathing and sleep in Prader-Willi from infants to young adulthood. In Queensland, contrary to what we heard before, it was the respiratory department that started the Prader-Willi clinics and started to do things with our endocrine fellows, and we weren't reticent in the beginning. It's come. I have no conflict of interests. Breathing. I thought I needed to explain because some of the terminology gets quite confused between people, and one of the difficulties why I've used the word breathing rather than respiration is technologically we talk about breathing in and out, and that's respiration, but if you go to the cellular level, we talk about respiration in a cell in the way oxygen and glucose and everything. So sometimes we're talking about different things and using the same terminology. And I also have a personal dislike for anybody who abbreviates because I don't know what it means. And that's my age, I think. But we need oxygen and we breathe to get oxygen in, and then the blood takes the oxygen to the cells to do normal function. And the brain cells require two primary energy sources. One is oxygen and one is glucose, and we've got to get both of them there to get things to function. Cells in the rest of the body, as you'll hear from the metabolic people, can have different metabolisms, but you still need oxygen to make it work. Breathing also eliminates carbon dioxide, and it's the main gas that we breathe out, so that all of you have taught the kids to breathe in oxygen, breathe out carbon dioxide, because that's good for our trees. Lungs and chest also have no spontaneous action in their own right. They require a message from the brain to tell the chest to move and for the lungs to do what they need to do to get oxygen in and carbon dioxide out. Our counterpart in the chest, the heart, it has an inherent knowledge of how to beat without any messages. And the messages actually tell it to go faster or go slower. But if there is no message sent, there is no breath. So that there's no, and the degree of that message sending has to work to get enough oxygen in, to get the blood happy, to get the cells happy. And the priority for that oxygen is actually to the brain. We know, and Tom Keynes did the studies in the 1980s and again in the 1990s, showing that individuals with Prader-Willi respond slower to low oxygens and high CO2. The CO2 in us all is the faster responder. We all respond to CO2 increasing much better with breaths, increasing breathing size and rate than oxygen. If we respond to oxygen, it's late in the response curve. So we don't want to see people desaturating, because you should have breathed up before that with a CO2 response. Sleep. Sleep medicine, and I have been doing sleep medicine in the 1980s, and I really would like everybody else now to know that other doctors just do wake medicine. Because it makes no sense to call it sleep medicine. Respiratory started in it because the respiratory system is vulnerable in sleep. The brain is the principal organ that requires sleep. Muscles don't require it. The gut and everything don't require it to work in the way they need. But brain cells need it. We now know that brain cell migration, myelination, increasing the nerve network and the electrical network is sleep dependent. You need the complex sleeps. Infants inside mother's abdomens spend most of their time in rapid eye movement sleep when they're non-moving. And we know that children, when they're first born, spend nearly 50% of the time in rapid eye movement sleep. And then they develop the other sleep stages, of which there are 5 subsets. And I do stress that wake is part of sleep. Everybody has some awakenings every night. Most of you aren't aware of them if you shorten them down to microseconds, but you still would see it in a brainwave activity. Infants and children require more sleep, and the hypothesis, but we have no proof of it yet, is that because they've got rapid growth of the brain still happening, and everything in their life is a new experience. It has to be laid down into memory. And we know that both short-term and long-term memory are sleep dependent. There have been tests done where they teach people a complex set of skills, and 8 hours later retest on those. If you've had a sleep in between, you will do much better at the retest than if you have no sleep. And the longer you're sleep deprived, the worse your repeat on that, the better you are. So all the students out there should be going to sleep and then doing their exams. We also know that sleep is that the muscles lose tone. You go floppy and ragdolly. The chest then goes smaller. So the breath size is smaller, and sleep is thus a stress test for my breathing system. And if the breathing system is not working well, then sleep is where we'll find out what's gone wrong with it first. Everybody knows that if you get a cough or a cold or any of the flu seasons, that you wake at night. And you wake at night because your breathing is not as good in the sleep state as in the wake state. Brain, though, craves sleep and REM sleep. If you sleep deprive someone, they will still have naps, and you'll see them nodding off, and we have it all the way through our safe driving on the roads now, revive, survive, sleep. And we need it. So the brain will put up with low oxygens, high CO2 eventually just to get you to sleep so it can do its housekeeping and to do things it needs to do. The oxygen requirement in REM sleep, and I've tried to say that how important it is high. It's higher than what most of you are doing now, sitting, resting, awake. If I did the very sophisticated things called PET scans, where you're looking at activity in the brain, most of mine now, I'd have some for movement, some for thought, some for anxiety and tension, but I'd have areas with no blood flow. But if you did it in REM, the whole cortex is lit up. The blood flow to the brain is maximum in REM sleep, and so is intracranial pressure and things. So sleep is important for the way the brain works, and it's a stress test for breathing. All problems in respiratory are better seen in sleep than other things. So that gets us to the disorders that we look for. Infants with Prader-Willi, we know have very low tone. When I was first a general paediatrician, we often thought they had neuromuscular conditions, and many of the families here I can see with older children would have had misdiagnosis for the first 12 months until the tone improved. The low tone gives you a decreased chest wall movement and a smaller upper airway. Because it's a circle, it relaxes with low tone. It's floppy everywhere. In my experience and in our sleep lab, any child who has difficulty feeding, suck, swallow, you remember the next thing after you suck, swallow is breathe. Then you will, if you can't suck, swallow successfully to weight gain, you almost certainly have a respiratory element of dysfunction. And unless people look at oxygenation and CO2, it won't be found. In our clinic, nearly 50% of the children who have difficulty feeding in infancy in the first 3 months will also have difficulties with oxygenation, and therefore they may need therapy, and their therapy varies from supplemental oxygen to full non-invasive ventilation for the first 3 to 6 months, and some of the children who don't get the improved tone and improved chest volume can stay on non-invasive ventilation through to 5 and 6 years of age, even with growth hormone. The treatment varies from helping with beads to all the supplemental and all the non-invasive things, but if we don't look for it in infants and just look up at oxygen saturation profiles, we often miss it. Growth hormone, it stimulates the BMR in mind, so basal metabolic rate. It makes cells want to do things, increases the energy, and therefore every cell will need more oxygen. If the breathing system is unable to do anything more, if it's already working at maximum, so you can do a sleep study or do an oxygen profile and it's normal, but it's normal with that energy requirement. If you then give it a higher energy requirement, give it growth hormone, and in the first 3 months, growth hormone is, in my thing, it's making the body ready to do the things that are going to be positive, ready to give you better body muscle mass, length and everything. But in that time, it also has to up the respiratory parameters. And when we re-looked at all the incidences of events with growth hormone, nearly all were across the board. Some of them were due to obstructive sleep apnea and obesity. Some of it is due to the small infant, not yet knowing how to take breath sizes and eliminate CO2, so central causes of respiratory failure. So that sleep studies required to see that. We see only if the children are doing well, a small number, but I can see faces in the audience where we've had to stop the growth hormone because respiratory parameters worsened, higher CO2s, bigger desaturation, instigate therapy, and then continue with growth hormone. It takes, from my understanding, about 6 months to get the good muscles. And once you get the good muscles, then growth hormone, you can wean off your therapy. Obstructive sleep apnea, normal breathing awake and sleep is quiet. You should never hear someone breathe. Most parents, when they've got a newborn baby at home, go in and wake them to make sure they're still there. Rather than, if it's noisy, it's abnormal. If the noise comes from the upper airway, it's various forms of snore. And the loudness does not predict severity. Sometimes quiet noises can be just as severe. If your airway's just open, it makes a tiny noise. And wheezes are crackles of what we hear in the lungs when the airways are too small further down. So that the noise, respiratory people like having noises and diagnosing the noises as they go down the system. And the treatment at all times is aimed at improving the airway size. The lymphoid tissue, adenotonsillectomy, tonsils and adenoids are just part of the glands of the neck. As we are at pediatric age, they get lots of infections and they make them memory cells so that you don't get the exact same infection again. So tonsils and adenoids get big and small. They got labelled in the 1700s because doctors could visually see them. But it was not to the 1900s that with microscopes that we knew they belonged to the lymphoid system. And that's why they sometimes can be big and sometimes can be small in the same person with different times of the month that people look. From my point of view, taking adenotonsillectomy is like taking the furniture out of a room to make it bigger. And that's what we achieve. Nasal mask CPAP, which is the other, blows the airway up and maintains it at the same size as the awake size. So it won't let it collapse. Prader-Willi and toddlers, there's improved muscle tone with or without growth hormone, and most times breathing improves from the infant through to the toddler. The infants also, as you probably get more in the way of bronchiolitis and others because of the small airways in the chest with the low tone. Growth hormone enhances the growth of the tonsils as well. There's a study by my counterpart, and he is not related, and his name is Mark Harris. And you can understand how difficult it is in a hospital to have two of us. That the adenotonsillectomy size is larger in children with Prader-Willi and growth who have had growth hormone than if they don't have growth hormone. So T's and A's is our first line, but it needs to be in a hospital where people understand the higher anaesthetic risk of children with a low CO2 and O2 responses. So the complications post-operatively will be less if it's in a hospital where people know the risk rate. The other thing is, in Australia's data, children with Prader-Willi have an instance of secondary bleeds higher than the norm, but it's still low. But it's double. We expect it in 1 in 2,000, and in Prader-Willi we're getting it about 2.5 in 2,000. So it's just a bit higher. Our second line therapy is mask CPAP. In childhood, it's relatively stable from a respiratory point of view. We monitor for the OSA, if they're sleeping well, and we can now ask, is there a noise? Because the noise will be something that people know about. But we need to also monitor for chronic bronchitis, because the low tone and the low response to CO2 and O2 can result in a poor cough reflex and chronic bronchitis, plus or minus some bronchiectasis at times. So we need to make sure that all coughs get better within a 4-week period. We also need to monitor for obesity and respiratory failure associated with obesity. Central control on respiratory failure. When the brain is hypoxic, its central control of how to breathe becomes less responsive. So if people have, whether it's obstructive or whatever, if you get high CO2s above 50, the brain becomes less responsive to how it should breathe, and so you get mixed pictures. You get both central and obstructive apnea, and instead of just having CPAP blow, you may need something to help you breathe in and out. The chest wall with obesity becomes heavier, so it's harder to do it, and if your muscles aren't strong enough, it becomes more difficult to breathe and the breath size decrease. And if you should get scoliosis, then the ribs can no longer move on the back of the spine to get a big breath. Then your breath size goes down as well. Respiratory failure is any time that the CO2 is abnormal. It can be acute with infections, or more likely in individuals with obesity or restrictive lung disease, it's chronic and insidious onset. And it's very difficult for anybody to tell when the CO2 is up in someone without tests and without looking for sleep studies. Individuals with Prader-Willi, we know for the degree of obesity, the degree of scoliosis, and with respiratory infections, develop respiratory failure sooner. And we believe that that is due to the blunted O2 and CO2 responses. The other thing that happens as children with Prader-Willi become young adults or teenagers is hypersomnolence and narcolepsy, and I should have, and I apologise to people, should have put in this also the diurnal or 24-hour circadian rhythm abnormalities. The hypersomnolence and narcolepsy in the Australian cohort occurs in about 20% of the teenagers. Sleep attacks when individuals should be awake in the daytime. Requirement for sleep is greater than expected for age. And we diagnose it with actigraphy plus sleep studies. Actigraphy are like watches. And if someone is unable to wear a watch, they're a bit like your Fitbit watch. The Fitbit watches work, but somehow the company doesn't want to share its data with us. And we as doctors like to share data, and we like equipment that shares data. Narcolepsy is if the sleep attacks are REM sleep onset, and we have 10% of the population that fit the diagnosis of narcolepsy with REM sleep onset, excess sleep on both sleep studies and a thing called MSLT, multiple sleep latency test. Hypersomnolence occurs in another 10% of individuals with Prader-Willi, where it's more slow wave sleep and non-REM sleep excess and an increased need for sleep. The treatments for both are similar. So in the teens and young adults, our treatment is really looking for treating OSA and preventing respiratory failure. And we had a higher number of individuals who need non-invasive ventilation support. That's bi-level support, and it's a higher pressure to assist you to breathe in, and a lower pressure so when the chest relaxes, you breathe out. The masks, nasal masks or pillows or full face masks, depends on everybody's face shape, and the support machines are all digital and surprisingly small for their complexity. I can send someone home with a machine the size of a shoebox that is as complex as the big ventilators in the intensive care. But it's underestimated many times when children or young adults say they're on these machines. People think it's just for snoring and forget about the respiratory failure. In Australia, we're fortunate that most states will, if you get a healthcare card, will supply all the equipment. The thing that I have found with individuals with Prader-Willi, the majority are easy to instigate this therapy in, because if it makes them feel better, they will wear it. And if they sleep better and feel better the next day, they wear it. And some of the obsessionality that may be part of the personality, once it becomes routine, they have to have it to go to bed, like a teddy bear or something else. If I haven't got my mask on, I'm not going to sleep. And we've had great success in instigating and normalising people's gas exchange. The masks come in all sizes and shapes, and the new rest bed mark is quite cute. The giraffe. They were getting better and better. When I started, we had a choice of 4 masks for children. Now we have a choice of over 30 masks for children. So it's got better as time's gone on with technology. These are the ventilator support machines. The top 2 are CPAP machines. All the others are ventilators, and they're not much bigger than the originals. Teens and young adults, when they come to our sleep medicine clinic, which is a combined respiratory and sleep tech, we will ask them about whether they're somnolent. We will do MSLTs and actigraphy. The medications for it are stimulants, dexamphetamine, modafinil here in Australia. The side effects though are on behaviour and personality, and often patients have needed to cease it, and often parents are unsure. They may be awake, but they're not sure if the school is reporting appropriately. So we often do what's called an N=1 trial. We'll disguise the medication in capsules, and they'll take placebo for 1 month, active drug for 1 month, and we won't know, and the parents won't know, and the patient won't know. And we disclose where it is 4 months later and try and work out whether it was a positive or a negative effect on personality, if it's helped with their wakefulness. But we often still treat to scheduled napping, which is historically how narcolepsy was treated in non-Prader-Willi patients, and it's very effective. And having scheduled naps at scheduled times, it has to be that you're woken. You can't keep sleeping. So you schedule the naps after actigraphy and try and work out the best time and how to put them in, and wake someone after 15 minutes so that they then get on and able to participate. We do this with schools as well, and we've done it with workplaces. I've left it fairly open at this time because I thought that the questions would be more relevant to the group, and I'm happy to answer them. I'd like to thank the organisation committee for asking me to speak, and I'd like everybody to remember there are 2 organs in the chest, and the breathing one is the important one. Thank you.
Thank you, that was terrific, and thanks for helping to get us a little bit back to time, but I think it's good to have a chance to ask questions. So any questions? Any burning questions?
Thank you, Margaret. You alluded to circadian rhythms, and it's come up a couple of times this morning. Do you have anything to say about that and sleep?
Yeah, there's it seems to be more from adolescence onwards that circadian rhythm becomes more reversed in individuals with Prader-Willi. In other words, they're awake at night and sleep in the daytime. If you wake at night, though, you first of all need a sleep study to exclude a reason to be waking up at night. And then we would use actigraphy to try and find out how disturbed the circadian rhythm is. When are you awake? When are you asleep? Over a 2 to 3 week period before starting to try to medicate or behavioural manage it with the psychologists. Honey Hustler, one of our developmental paediatricians, would love to be able to measure melatonin. Melatonin comes from the same pituitary hypothalamic area that all the other hormones come from, and we think it'll be out of kilter, but melatonin is difficult to measure because you need to measure it every hour. So we need to get better at measuring saliva so that you can take a test quickly with just a pad in the cheek rather than with any blood tests. The other thing I need to say for people here in Australia, that most of the melatonin sold over the counter has no active ingredient in it. Unless you go to a compounding chemist, you cannot guarantee there will be an active ingredient. Unlike the US, where melatonin was introduced, I think, as a drug, here it was introduced as a food supplement back in the 1950s and has never had to pass any regulations. So be very careful if you think people aren't responding to melatonin to know whether it's active or non-active ingredient. The University of Queensland tested over 70 over-the-counter melatonins to find nothing. A lot of it's homeopathic, so meant to be very small.
Sorry, there's a gentleman at the back.
It was great to hear you speak about individuals, I think they were mainly children, who obsessively kept their CPAP masks on. I've just sought permission from a Prader-Willi syndrome adult.
Who doesn't?
Who, I don't know about obsessionally, but certainly does not keep his on. And he said it's okay for me to ask this question. Do you have any suggestions for how such a young man can keep the mask on rather than have it on for, well, one of the signs show, 2 hours a night?
The key from my aspect in our lab is to make sure the interface is right. In paediatrics, we are more active in getting all product lines into one system, whereas many of my adult colleagues in adult labs will send people to specific companies to get masks, and you need to find the right mask for the right face, whether it's pillows, whatever. And you need to make sure that the sleep study after you're on is improved, because you need to wake feeling refreshed. If you wake feeling refreshed, you're much more likely to do it again. You can see that we're fairly, someone said that our unit is obsessive as well, in that we will always do 3 nights when we titrate CPAP or non-invasive ventilation to any child or young adult. In Australia, it's through to 18, and suddenly at 18 you're an adult, no matter what. And the reason that paediatric hospitals don't like you after that is we don't get paid by the government. So there's a distinct difference at that time. I think people need to go back and try. I think you need to go to your adult lab and say to them you want to make sure that the pressure they set is correct.
Thank you. For an adult with obsessive sleep apnea, obstructive sleep apnea, how often, it's well managed, but how often would you recommend a full sleep study?
If their weight is being constant and they're well, probably every 2 to 5 years, depending on how. But if weight gain or weight loss occurs, then you will need to significant changes in your BMI, your body mass index, then you would need a sleep study to make sure the pressure is right to maintain the feeling of refreshment in the morning after a good night's sleep.
So my daughter is almost 4 years old, and she was on CPAP for about a year and a half. We did a sleep study, got off of CPAP. She snores quite a lot. So do you think she should redo one?
She needs another study to look. We can't guess. Because they've got blunted CO2 and O2 responses, my ability as a clinician, and tests have been done on that, is a 50-50 to guess whether it's right or wrong. And therefore I would strongly hope that everybody in this audience takes the option, because our Commonwealth Government has just asked what people would want in sleep medicine and looked at it and asked for input. In Australia, on the East Coast, there are over 90 adult clinics for sleep medicine, and we have 6 paediatric clinics.
In Singapore, there's 2.
Yeah, I know.
Well, thank you. Oh, sorry, got one more.
You mentioned melatonin. I'm just wondering if you can comment on any clinical experience you have using prescription-grade melatonin in kids.
Melatonin works with the behavioural management together with it. It won't work without. It's not a sedative. It makes you more likely to go to sleep. Once we've got some actigraphy, the difficulties of whether it's sleep initiation or sleep maintenance, and sometimes you need both. Sometimes you need the short acting to help with sleep initiation, and then the circadian, the long acting, to keep sleep maintenance happening. And you rarely need doses over 6 milligrams because it tends to peak at that. But it won't work that if in the mornings you must have bright light. In Queensland, that's easy. It's called the sun. In the Northern Hemisphere, they create glasses with bright lights across the front to shine directly in eyes because there's not as much sunshine. But you need bright light for a minimum of 40 minutes within 2 hours of waking. It's got to be on your face and on your eyes. That squinty morning sun. There's no UV in it, so it's not a high cancer risk or a high cataract risk, but you need that bright sun to actually help with some of the circadian rhythms, and my colleagues in endocrinology will tell me which of the pituitary hormones are dependent on that light source in the mornings and the surge in the morning, so that then you're much more likely to go to sleep at night. At night, you should have a dark room. If you have a light on, it should be a red light, no blue lights. Any blue light or white light in your eye will make you wake when you come to your normal wakings in the normal sleep pattern, whereas if your eye is not stimulated, you're much more likely to go back into sleep.
Oh, it's very interesting. So there's short and long acting melatonin. Okay, so we all have to buy a red light.